Hi everyone, we'll just wait a couple of seconds while everyone gets into the webinar. Okay, so we might get started. Good evening and welcome to the Australian Centre for Value-Based Healthcare webinar, Digitally Enabled Value-Based Care in Colorectal Cancer, a discussion of Cabrini Health and the Alfred's experience implementing a global standard for patient-centred outcomes monitoring. I'm Emma Hoban, the Policy Manager at the Australian Healthcare and Hospital Association, and it's my pleasure to be with you today. Before we get underway, I would first like to acknowledge and pay my respects to the traditional owners of the lands that we are all meeting here on today, and recognise the continuing connection to land, water and culture. I am currently on the lands of the Ngunnawal people in Canberra and pay my respects to their elders past, present and emerging. We're all set for a great discussion today. And I'm sure we'll inspire some great questions. We have a dedicated Q&A session at the end of the webinar, but feel free to put your questions in the Q&A function at the bottom of your screen throughout the presentation. So in today's webinar, we will be joined by Professor Paul McMurray, who is a colorectal surgeon and holds the Froelich West Chair of Surgery at Cabrini, a joint venture between the Cabrini Institute and Monash University. Since 2009, Paul McMurray has headed the Cabrini Monash University Department of Surgery and has played a pivotal role expanding the department's role in clinical research, quality assurance leadership in the Australian medical community and health promotion, in raising considerable awareness about bowel cancer prevention and screening. Professor McMurray has published over 50 peer-reviewed papers, with his research focused on answering clinically important questions that translate into better quality patient care and outcomes. We will also be joined by Dr. Sophia Dasgupta, the Director of the Outcomes Research at the International Consortium for Health Outcomes Measurement, or ICHOM. Sophia is responsible for the development of harmonisation of ICHOM's set of patient-centred outcome measures, and Sophia has a background in medical science, holds a PhD in immunology, and has worked closely with clinicians in academia and biotech companies. She previously worked at ICHOM, leading the development of the ICHOM set for chronic conditions. And prior to joining ICHOM, she worked with the NHS hospital, leading the measurement of improvement programs, including the high-profile patient safety program. We'll also be joined by Dr. Ron Tenenbaum, CEO and principal founder of The Clinician. Ron is principal founder of the digital health company, The Clinician, bringing with him 20 years of international healthcare experience. Previously, Ron has a long career in medical training and working as a neurosurgeon across 4 different healthcare systems. His interest in technology, particularly from driving more patient-centred and value-based healthcare systems, led him to found The Clinician in 2015. The Clinician exists to enhance the dialogue between patients and providers in a bid to improve health outcomes. To date, their platform has been implemented across Australia and multiple other countries, including at a national level in both Singapore and Israel. So now I will pass over to the presenters today, starting with Dr. Sophia, and you get to hear about their great experiences implementing the PROMs and PREPs.
Thank you, and hello. Thank you everyone for giving me the opportunity to speak with all of you today. Let me share my screen. All right. So, well, I will start with a bit of ICHOM history. So we were founded in 2012. So this is exactly 10 years anniversary for us this year, by Professor Michael Porter, Stefan Larsson, and Martin Ingvar, as a non-profit organization that is looking to drive industry towards the value-based healthcare, also known as VBHC. Value-based healthcare is the healthcare delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. In the value equation, measures value by comparing the health outcomes that matter to patients against the cost of delivering those outcomes across the full cycle of care. And under the value-based care agreements, providers are rewarded for helping patients improving their health reducing the effects of and incidence of chronic diseases, and live healthier lives in an evidence-based way. So ICHOM really exists to transform the healthcare worldwide. Our mission is to unlock that potential of value-based healthcare by defining the global outcome measures that matter most to patients and driving the adoption, validating and reporting of these measures worldwide. Our sets, and I'll talk a little bit more about that, are free of charge and support the global we support that global adoption of the sets by the network of scientific leaders and clinical leaders that help us transform the implementation of the sets. So ICHOM drives this mission, as I said, by defining global set of patient-centered outcome measures. On the slides, you can see starting 2012 up till now in progress, we delivered over 40 sets, developed over 40 sets across many different medical areas. We have a family of sets, for example, that cover the oncology conditions. We have cardiovascular, cardiometabolic conditions, such as atrial fibrillation, diabetes. We have a whole portfolio of sets for mental health conditions, including anxiety, depression, eating disorders, psychosis, and so on. We also focused on more kind of age-specific groups. So, for example, pediatric conditions. And also we have a sets that look across a wider group population of patients, such as overall adult health, overall pediatric health standard sets. We estimate over 45,000 downloads of our sets globally since the launch. So how are ICHOM sets developed? So we use a published methodology. We work with a group of experts, we call them working group. That includes the clinicians, but also other healthcare staff that is involved in the care of a patient. We also include the researchers, especially those who have expertise in patient-reported outcome measures, registry leads, and of course the patient representatives or patient advocates. On this slide here on the left, you see a guidelines that the working groups are given in order to determine what should be included in an ICHOM set. So as you can see from the top, it's firstly the outcomes need to be defined around the specific medical condition itself, and not a certain specialty or procedure. The ICHOM sets are minimum sets that focus on what matter to patients, and we know we can't capture every outcome relevant to the disease, so we really need to focus on the ones that matters most. So it's a bit of a balance and compromise from our working group experts when we think about what should be included. Very important to do ICHOM mission is that patients are directly involved in the development of the sets. They participate in all our meetings and provide great amount of input and perspective. So they're basically part of that working group. Patient-reported outcome measures, or PROMs, are also always included in every ICHOM set in order to capture direct reports from patients about things like symptom burdens, functional status, and health-related quality of life. We also include the risk factors to help facilitate meaningful comparison of the data. And lastly, the sets need to follow certain defined timelines relevant to the disease area. So let me give you an example. This is the colorectal cancer standard set. The set was developed under the leadership of Dr. Rob Tollenaar and Dr. Cornelis van der Veld. The working group of experts, as you can see here on the left, included individuals from several different countries with lots of different expertise. On the right, on the right-hand side, you can see a snapshot of what is included in the set. So you can see here we have some more, I would call it typical clinical endpoints, clinical outcomes like survival, hospital admission, and end of life acute complications. But also we included here the outcomes that are patient reported, such as pain and fatigue, depression, health-related quality of life. So these are all the ones that I highlighted here in orange. And you can see that out of 14 outcomes included in this set, 8 are patient reported. So 8 outcomes are coming directly from the patients. I mentioned it before, all ICHOM sets are freely available to promote that global adoption. To access the set, please visit ICHOM Connect on connect.ichom.org to register for free and download all materials. In terms of the materials, what you will find there is firstly the data dictionary. So all our sets are written down as an Excel documents that include all the variables, definitions, inclusion criteria, data source. This is a perfect document, especially for the IT team or those who will be designing how the data will be collected. We also have what we call a reference guide. This is basically a PDF version of a Excel data dictionary. I think some may find it much easier to read. And thirdly, we also have a scientific publication. So all our sets are published in peer-reviewed journals. I mentioned the methodology we use. It's something which is published and we use it across all our sets. And really the manuscripts are a great addition to better understand the process behind the set development, and also why working group would select certain measurements and certain maybe not include in the minimum set. So I would encourage everyone to visit that webpage. So this is actually just last slide. I said a lot about, what we do and about our sets, but how healthcare organization might benefit from implementing this sets. And I know the next 2 talks will give you a little bit more about it, but I highlighted here, I think, like key reasons or main things to think about. So these are just a few, but number one, it's really to enhance the patient-doctor communication and set decision-making based on what matter to patient. And this obviously comes with increased satisfaction and engagement of clinical employees and patients. And I think you will hear a little bit more about that, but how you use that data to have that more meaningful conversation with the patient and really address what matters to them and help them guide through what might always is rather stressful time in their lives. Number 2 is data from ICHOM sets can be used for quality improvement initiatives. There are many different ways of using it, but it's definitely a type of information that could be used in this kind of programs and ultimately leading to improved outcomes on the, for example, department level or clinic level. And finally, on the larger scale, once a provider achieves better outcomes that come with this increased, that will come with the increased volume of patients coming to the hospitals and the providers through increase of the referrals. And of course, better positioning in negotiating value-based contracts. So that's all from me. Thank you so much. And I will hand over to Paul.
Thanks very much, Zofia. That gives a really important insight for us into why ICHOM is the obvious standard data set to use when you're implementing a new clinical data collection process like patient-reported outcome measures. So I wanted to talk a little bit about our experience at Cabrini Health and with our clinical and research affiliates, including the Alfred Hospital. About how we've developed this program here in Australia and how we see ourselves taking this forward into the future, both for the betterment of patients individually, for research, and how we're going to link this with our established clinician-led data sets that we have in place here at the moment. Particularly want to acknowledge, obviously, Cabrini Hospital and Monash University, but also, very importantly, Let's Beat Bowel Cancer, our public awareness and fundraising group, who've been absolutely pivotal in helping us to raise the funds that have been necessary to drive these initiatives, going right back to the time of creation of the colorectal neoplasia database. This was developed between 2006 and finally rolled out early in 2010, initially at the Monash-based hospitals, but then the Colorectal Surgical Society of Australia and New Zealand approached us in 2011 about using this as the platform for the binational colorectal cancer audit, the BCCA, which has just released last week their 2001 report. I think this is now the 9th consecutive annual report based on the data collection system that was developed here at Cabrini. And I think that 90 centres is now out of date. It's well over 120 centres around Australia and New Zealand that are using this as their clinician-led database for measurement of outcomes and for quality assurance and research in treatment of colorectal cancer. And I think it's important to emphasise that the traditional outcomes that we've looked at historically prior to the last half a dozen years or so have related to doctor-reported outcomes, the stage of the cancer, the operation that was undertaken, whether or not the patient survived, what complications they may have had, what chemotherapy or other adjuvant treatment they had, and their follow-up. And of course, this is all data that's being entered by clinicians. So what's really been missing here is the patient's voice. We, at this stage, have up until the last few years really had no role for the patients whatsoever in reporting their outcomes, but PROMS provides them with a voice. And it's important because bowel cancer is a common condition. There'll be 17,000 new cases per year in Australia. About just over half of those patients will be cured. There's been a considerable investment by the Australian federal government in having the National Bowel Cancer Screening Program. The profession as a group, particularly the colorectal surgeons through the BCCA audit, have played a lead role in reporting these outcomes. We know that bowel cancer is stage dependent in terms of treatment and outcome, but it's important to note that we do harm in treating people. Patients with bowel cancer suffer adverse effects both from the cancer, but also from the treatment that we impose on them. So I've just got to lock there, that's it. There are outcomes that we're not traditionally measuring through our clinician-led data, such as quality of life measures, both before and after treatment, time off work, sexual function, pelvic organ function, including fertility, the impact that the formation of a colostomy or an ileostomy, a stoma, may have on these patients, the infamous anterior resection syndrome, where people having part of their rectum removed and replaced with an artificial rectum made from other portions of bowel have significantly diminished bowel function with continence, sometimes incontinence and frequency. We affect their mood, we can create depression, and importantly, with more modern chemotherapy, patients can suffer significant morbidity from chemotherapy-related neuropathy. And traditionally, we've not been measuring these outcomes. So how do these PROMs work? Well, patients are recruited both to the colorectal neoplasia database and to PROMs. So if you're being treated currently at either the Cabrini Hospital or at the Alfred Hospital, each patient will be invited to participate both in the database and to participate in PROMs. There's an automated SMS and email that's sent to the patient so they can put in their background data. It's very important, of course, to have a measurement and an idea of what the patient's function was like prior to their treatment if we're going to do comparators with post-treatment data sets. They're sent a baseline quality of life data set to fill in, importantly, the ICHOM data set and some key pelvic floor functional questions. They can fill this in online. It's very simple, takes only 10 to 15 minutes. They're then sent automated reminders at key timeframes, both to remind them if they haven't filled in the data, but also at key timeframes after their surgery and during follow-up, for particularly the first 5 years after their initial treatment, which is the time when we would generally believe that they're most likely to suffer from either recurrence of their cancer or from adverse treatment effects related to what we're doing to them. Importantly, this data is aggregated for research purposes, but as Zofia has pointed out, this data is also available to the clinician at the time of consultation. So the traditional conversation that would take place between a clinician and a patient after treatment of cancer generally relates to the surgery and the treatment itself. But what we don't tend to ask people is about their sexual function, their quality of life. What's their mood like? Have they got back to work? How's their partnership and their family relationships going? And these are obviously really important endpoints for us to be aware about, And so now these are being recorded through these PROMs. So what does the clinician actually see? This data is available to the clinician real time during consultation, so that using the software platform developed by the clinician and by Ron's group, you can sit now and see where your patient sits baseline in terms of their bowel and pelvic function, their quality of life related symptoms, and other parameters as we've outlined. I haven't demonstrated all of them here, but sexual function, return to work, bowel function, whether or not they have the so-called low anterior resection syndrome. And this is important because we can actually intervene to help patients if they are suffering from these adverse effects of our treatment. There's fantastic pelvic floor physiotherapy and other supports that can be put in place to help people with their pelvic symptoms after they've been treated. But unless those symptoms are actually highlighted for the clinician at the time of consultation, then we're not aware of them and we won't be able to intervene. So PROMS allows us to do this. We can also, of course, develop research from the aggregated data, not just on the treatment of or the impact of the treatment on quality of life, but on their sexual dysfunction, low anterior resection syndrome, and of course the impact of neuropathy. But what this allows us to do is to take all aspects of patient care linked together in a cohesive platform. This is linked to the clinician-led data platform that we've been collecting data on now for over 10 years. So we can link together treatment and outcome data, not just from the clinicians, but also from the patients. And we can also link this to some of the tissue platforms, such as organoids and tissue microarrays, which we're studying here at the moment. And also they can be linked to clinical questions informed by leading clinicians. Are different types of surgery any more or less likely to cause low anterior resection syndrome? Are they more or less likely to cause pelvic floor dysfunction? There's constantly new treatments that are implemented into the treatment of bowel cancer. We changed from open surgery about a decade and a half ago now to laparoscopic surgery. More recently, there's implementation of robotic surgery. But what we don't know is we've been carefully studying the impact that this has on stage and surgical outcomes as measured by doctors, but not according to the patient-reported outcome measures that are reported by patients. So now we have the opportunity to take things that step further. Why is this platform unique? Well, this is the first time that there's been a cohesive package of patient-reported outcomes linked to clinician-led data that's available to both patients and to the clinicians themselves. We're not charging the patients. There are some platforms with PROMs in Australia where to engage in this, I think the patients are now being charged over $1,000 using other platforms for patient-reported outcome measures. We're not charging these patients. As I've said, it's linked to clinical outcome data, multiple translational research projects, including organoids and tissue microarrays. It's obviously important for clinical trials, and it, of course, assists with patient advocacy. So how well is this working? Well, since the beginning of the year, the two barriers to getting this up and going, of course, after you've got the platform in place, uptake by the clinicians who have to refer the patients, and then acceptance by the patients. Now, what I can tell you is of the 98 patients who've been referred links to participate in PROMs, the completion rate so far has been 86%. Now, when you think that some of our patients, a significant proportion of our patients are over 85 years of age, they're not necessarily IT savvy, that's a remarkably high completion rate. And I think that we'll be able to encourage and enhance this further by increasing our audiovisual supports, not just for the patients, but for the clinicians who refer them in and also the clinicians that are treating them. Perhaps the lowest level of uptake has been from the clinicians so far, both in terms of referring patients and also using the data that's available to them. But I'm confident that as people become more familiar with this process, uptake will be improved. And importantly, we're aiming now at rolling this out more broadly to more centres. And we've been together with the clinician in discussions with the BCCA to allow a platform for financial sustainability and uptake of the patient-reported outcome measures, not just at Cabrini and Monash and the Monash University affiliated hospitals, but also at hospitals more broadly across Australia and New Zealand, and naturally we'd welcome international partnerships also. So how did we put this together? Well, it's a big group of people that have been involved here. That's in front of you. You can see the Cabrini Monash Department of Surgery team members. It's involved the clinicians, the PROMS working group, and I want to particularly thank Raymond Yap, Steve Bell, Chip Farmer, and Karen Oliver, who were involved in that process, the team from the clinician, the surgeons, financial support from the Colley Foundation, the Cabrini Foundation, and importantly, Let's Beat Bowel Cancer. But I particularly want to thank and acknowledge the work that's been done on this by Christine Georges, who's played an absolutely essential role in the integration of all of these working groups, dealing with people from many walks of life, and has been absolutely tireless in her pursuit of getting this product up to a point where it's at the quality that it is at the moment and has been rolled out as successfully as it has. So I particularly want to thank and highlight Christine's effort in this. So again, we'll welcome questions at the end. Ron, I think you're speaking next, so I'll hand over the podium to you.
Thank you very much. Okay. Good afternoon, good evening. Ron Tenenbaum from The Clinician. The Clinician is a digital health platform that focuses on patient-reported outcome measures. So a bit about a digital PROM program and how does it work. Usually the journey in the PROM program starts in a different platform, not in the actual PROM's digital platform, where the patient is being recruited. Sorry, just a minute. The patient is recruited, and the platform in an automated fashion starts sending reminders and invites to the patients to complete the assessment, whether it is at home or in community. Patients click on a link. They're presented with a web page that emulates a mobile app. It is a very clear design that allows them to quickly orientate and see what they need to complete, the status of when they're completing it, and when the information has been sent. Once the information is sent, it's being analyzed in real time and available for clinicians, for research, depending on who is using the platform. And as you can see, the information is available on individual level and population level, with the ability to benchmark the individual patient against the cohort. Our digital platform is called ZDoc. It sits between health information systems and the community. Patients are recruited usually, and I'll touch upon the specific project, but are recruited usually in an automated fashion from another system. Then the ZDoc platform starts communicating with the patients to collect and analyze the patient-reported outcomes, and sends it to the clinician where it's available on the screen, whether it is the clinical registry, the EMR, or the actual platform. Now, not for this project, but another project, the ability to collect the full range of patient-generated health outcome data includes also health devices, wearable devices, and medical devices. Again, here in this project, and I'll touch upon the extension of it in a minute, we focused on collecting the subjective data. Looking at the screens presented to the patient, I'll start from the left. You see that the patient can see the list of instruments that they need to complete. The platform gives them an indication of how long it will take them to complete. Then click on it, and they are guided through either a welcome screen or an explanation of what is the instrument is all about. They will then complete the instrument depending on the type of questions, whether it is a visual scale, whether it is a multiple questions or a single answer or a matrix. All questions, by the way, have been adapted from the original format of the authors to an approved digital format. When I'm talking about the approved digital format, these questions need to be standardized. So for example, the scale, the visual scale, needs to appear in vertical or horizontal, and sometimes the authors would like it to appear fully on the screen, so not let the application, for example, split the screen where patients need to scroll down to be able to see the available options. So all of these screens that you're saying are screens that's been validated by the actual authors in a digital format. When the clinicians view the information, they are looking in interactive charts and looking at trended data in real time. They can filter, use different weights. The platform comes with a default selection of weights, such as the gender, age group, etc. But customers can add different weights to those filtering, and the ability to download a PDF summary. Now, what we created here with the Cabrini team were a minimal and an extended report. The minimal report is a report that surgeons can consult while they have the patients in front of them. When I'm talking about minimal, I'm talking about, for example, the composites of quality of life, the composites of bowel and pelvic symptoms, or bowel and pelvic function. But the extended reports, which are the ones that they consult when they have a bit more time, drill down to the different domain of those either generic prompts or condition-specific prompts. With the Cabrini team, we implemented the platform into their existing workflow using two different streams. One was the patient onboarding that consisted in setting up and weaving into the clinical workflow the in-person exchange of information. So patients are being onboarded onto the project by their surgeons, and are given also a prompt booklet in a PDF format. They're then being sent a personalized invitation, either in an SMS or an email format, that invites them to complete their baseline with automated reminders that are sent to those patients that did not complete the assessment in time. The patient, again, they can just click on a link and they can access the prompts on their own devices, whether it is at home or at work. They don't need to come to the clinic to complete those assessments. What we've done with the Cabrini staff is beyond the training, we looked at how to minimize the burden by recruiting the patients into the platform. So again, with the initial phase, which we termed phase 0, the patients are actually being registered into the platform using 6 different fields, as you can see on the slide: first name, last name, their contact information, gender, and date of birth. But as we will go into phase 1 and phase 2, which I'll show you in a minute, we'll automate this process. So in fact, we're moving on to a phase where we're going to be integrating with the CRC clinical registry, and that will roll out in 2 subphases. One is the automating the patient enrollment. So there will be an automated data exchange between the registry and the ZDoc platform. So patients will be enrolled into the program automatically. And the other things is the PROM journeys in ZDoc will be triggered based on the specific registry event, such as the surgery date. The second phase of the integration foresees the actual PROM data. So this is the data flowing from the ZDoc platform back to the registry. And this will be coming into the registry in two different formats. One is an iframe widget, which will display the data, the chart right in the registry interface. And the other one is the actual raw data of the responses that will flow into the registry. So what's next for this program beyond the integration? First, it will be the delivery of multimedia education content. As you can see here, the example is of the lumbar spine surgery, but we will be adapting we'll be providing the multimedia content specific to the colorectal surgery. And the platform will automate the delivery of this education. Second thing is supporting multiple languages. So beyond English, we'll be supporting other languages such as simplified Chinese. And again, when we're talking about multiple languages, we're talking about standardized versions of those prompts in those languages. So it's more than often, it's not just the translation, it's also the cultural adaptation of the PROM instrument. Third, last but not least, is the actionable insights. The platform will support actionable insights that will be delivered to the clinicians based on the results that are received. Our key learnings and outcomes. First of all, for a successful implementation of PROM program, you need a very intimate collaboration with the stakeholders. There is weaving the PROMs collection and the analysis into the existing workflows. There's a change management where we learned that if the surgeons have a strong buy-in, the patients respond a lot better to the PROMs. So all of that is thanks to a very good collaboration between the different stakeholders. One very important, another important aspect is the mapping of the PROM program. Again, I'm sort of repeating myself, but it's important. It's weaving the PROMs into the existing workflows of the clinic. And the last but not least, it's the PROMs outcomes, the data that is collected that is providing a much better provider-patient communication and a more personalized and value-driven care to the patient themselves. I'm gonna finish with a slide that talks a little bit about the company, just a bit of a background. We're a digital health company supporting health organization, deliver better health outcomes and transition to value-based healthcare. We're headquartered in New Zealand. We have offices in Singapore, Australia, and Israel. And we're very strong on privacy and security protocols. In fact, with some of the countries that we work with, particularly Singapore, we went through national security review boards for the platform. So this is our bread and butter. And I just mentioned Singapore. Similar to Singapore, we've also been chosen by Israel as a national platform for patient-reported measures. There's a bit of a collection here of organizations that we work with, but I would like to highlight both the Cabrini and the Alfred that has been a champion customers and collaborators, and it's been a pleasure working with them. Thank you very much.
Thanks, Ron. So we'll now move on to questions. So if you have any questions, please feel free to put them in the chat. But we might start off with one for Sophia. How does ICHOM decide what sets to develop?
Yes, sure, thanks. So we really prioritize the set development based on few factors. So the disease burden, clinical engagement, and funding. So in general, we look at the conditions with higher disease burden that will receive a priority, because once developed, obviously the impact of that set will be bigger. The clinical engagement is also critical. and really refers to the availability of respected clinical leaders who are eager for such a set and are willing to develop it and champion it and adopt globally and work with us. And finally, it's the funding to cover the set development.
Thanks, Sophia. Now we've had a few come through the Q&A, which I see that you've answered, but I might just get you to answer and expand on these a bit more broadly, Paul. From Christabel, we have a question: how are you linking this to your EMR, presumably different platforms at different hospitals, and have you explored streamlining the prompts?
Thanks. Yeah, look, I think the prompts has been pretty much streamlined now. I think that question was asked before Ron had given his presentation, but I think there's a lot of streamlining that's built into the system and the software, the reminders, etc. But the EMR, both of these major data collection projects that we have in place, firstly, the clinician-led databases and also the PROMs, I've made them deliberately EMR agnostic because EMRs change with time. Different hospitals have different electronic medical record platforms. There's also patients that have been treated outside of major hospitals and outside of an environment where there are electronic medical records. A lot of these patients, well over half of patients who are treated for bowel cancer in Australia are treated in the private sector, and their follow-up will not necessarily be within a major hospital. And there's been a number of changes to the private healthcare sector to facilitate this and to allow it to happen with the level of excellence that we'd require. So that, there are now multidisciplinary teams, multidisciplinary meetings that are held in the private sector. And in fact, both of these initiatives have come from the private sector itself rather than from the public sector. So I think having it as EMR agnostic has been important because it means that everybody has an equal opportunity. The software platform is available to people whether they are within a major hospital or outside of a major hospital, including the patients themselves.
Thanks very much. I've now got a question which is probably for all of you, but maybe for Ron and Professor Paul McMurrough. The engagement of clinicians and patients and building into workflows is very important. Can you talk about any resistance by the workforce in implementation, and also how multidisciplinary teams work together using such platforms?
You go ahead, Ron.
Okay. I think that the resistance usually comes from not understanding the value. So as soon as you explain the value to clinicians and you make the information available to them, particularly before the visit in a way that they can consult it, probably graphical rather than textual, you get a lot less resistant. Then the resistant, I would say, with the ones that resisting it the most would be the clinicians that are a bit skeptic of all patients completing it. And yeah, I might just stop there and I'll pass it on to Paul that can talk more in depth.
I think there's a couple of things to consider. Initially, uptake for the clinician-led database was slow for the first few months. But after we wrote a review now, it must be 8 or 9 years ago, about data completion and clinician compliance with data entry into the clinical databases after the first 1,000 patients were entered in. And in fact, it was greater than 99.5%. So once people have had the opportunity to use these things, clinicians by their nature are inquisitive souls, just as patients are, and they want to know, they want to participate in these processes, and they want to see the good results and sometimes the not so good results that they're producing. So clinician uptake is generally very good. It has been slower here, but I think there's no doubt that the impact of us being on the tail end of the COVID crisis has had a significant role in that as well. It does require compliance, not just from the doctors, but from secretarial staff and other support staff to help get the emails started in the first instance. And all of those processes are proving incredibly difficult in this tail period as we resume normal activities after COVID. But I'm confident that it will continue to improve.
This question kind of builds on that one. It is talking about how there are a lot of challenges when it comes to digital health literacy levels across the workforce, both individually and across departments. How is this overcome in this particular instance?
Well, I'll start with that one, Ron. I think if you look at the graphical data that is presented and the explanations that are available to the clinicians, and I think from the clinicians' point of view, the uptake, their general knowledge of what these difficulties are and what it is that we're trying to measure is extremely good. So amongst the clinicians, I think that's less of a problem. Health literacy with the patients is always difficult, particularly in a diverse society like Australia, where people's grasp of English varies, their grasp of IT varies as well. But I think as we continue to develop audiovisual educational programs to assist patients with the process so that they understand how to mechanically enter the data, how to log in, and also the importance not just to themselves, but also to the community of participating in this process. They've been very highly motivated to do this. And it's been one of the rare upsides of PROMs, of course, that people who weren't necessarily quite so IT literate have been forced to become much, much more IT literate with entering data, online forms, using QR codes, etc. Things that people were reluctant to take up. Even our patients over 80 years of age, who in many ways are the most difficult to educate about these processes, have become much, much more proficient in the last 12 months. And so thus far, if you look at the uptake rates with the patients that we've had and the data completeness, if we're approaching 90%, I think by any measure, we're succeeding with that process.
Ronald, Sophia, do you have anything to add on that one?
I would just add that by simplifying the interaction with the patient is when you actually get the responses. So by just sending a text with a link, patients do not need to download any applications, and they can enter the instrument and go through a dedicated screen for each question. It's very easy to understand. It's easy for them to complete, particularly when it comes to their own language. I'll just mention an example that we had in Singapore, where we added the simplified Chinese to a project, and overnight the response rate jumped by 6%. Just that the elderly patient just understood what was asked of them. So there's ways to tackle the digital literacy.
We have another question here. Does the patient have access to the PROMS data they enter so that they can track their own progress over time?
Yeah, they do, no doubt. The patients can look at the forms as they fill them in. They can see their previous data and they can see how they're tracking. And that's important. Both they have a right to see that information, but it also helps to prompt them during the consultation. You know, consultations are often a time-pressured and interpersonal pressured process, no matter how easy we try to make it. And to have the patients having access to that data so they can say, look, I'm a bit worried, my quality of life is still at the lower end of normal, etc. It's a great reminder and prompter to the clinicians during those processes. We've also got a couple of hands up from Kate White and Jennifer Cottrell too. Kate, yes. I think you were first.
So they won't actually be able to speak in the webinar. They'll have to type their questions in either the chat or the Q&A, and then I can read them out to you. So the question I have here from Kate is, has there been any assessment of impact on workload of the health professional team? Recent studies have shown increase in workload that is not taken into account when planning implementation.
Yeah, well, at the moment, the question is, how do we best study this? What we've done is we've engaged the clinicians so that they are part of the process, they're part of the team, and we can then measure what their compliance is. Now, as I said, at the moment, it's moderate, but improving. And this is exactly the same as we saw with the clinician-led database. I think at the end of the day, you can adopt a carrot approach or a stick approach. We don't want the stick. The carrot approach is much better. And if this, let's call it a product, but if this platform and this process provides something really important for those clinicians, that it improves the quality of their consultations with their patients, it engages their patients and gives them a voice in terms of measurement of their outcome, then it is inevitable that those clinicians will be induced to take this up. there's no way that you can ever implement a new platform like this without it implying at least some increase in the workload of the clinicians who are involved. But inevitably also, I think if you make it attractive enough to both the patients and the clinicians, who are the two real end users of this process, then compliance will be excellent.
Great. I have a question here from Paul Siltzer. How do you tease out PROMs related to chemotherapy compared to surgery? Also, are we going to study chemo-related side effects through PROMs? And if so, do we need to collect significant data such as agents used and dose, etc.? This could be difficult.
Yep. Well, again, Ron, if you don't mind, I'll answer that one. It depends which database you're using, Paul. If you're using the BCCA database, then there is only a limited amount of information from memory about dosing and schedules of chemotherapy or adjuvant therapy that patients are receiving. Certainly in the extended data set, there's very extensive information about the dosing and duration of adjuvant therapy. So through that data set, we'll be able to gain important information. And look, it would be nice if we had that information more broadly across the entire BCCA data collection. But the reality is we don't need to collect infinite amounts of data to answer all of these questions. If you look at the extended data set now, from the last 10 years, there's about 4,500 patients that have got completed data entered within that. About half of them have had adjuvant treatment, so there's 2,500. And if you're collecting PROMs on all of those, you'll very rapidly see the sort of effects that you're looking for when you've got data collection to that level. So I think we just need to see the BCCA data collection set and the extended data set as two closely related but separate entities that serve different purposes. But without doubt, with PROMs linked to the extended data set, that data will be pretty easy to tease out.
Fantastic. And so just building on a point that you said before, Paul, Sarah has asked, how do you make the system EMR agnostic? Does the clinician enter the clinical data themselves?
Yeah, that's the way that it's been set up. So the BCCA database and the extended data set, the Cabrini Monash data set, it's all entirely clinician-led. It has nothing to do with the hospital. We do get assistance through the hospitals in different ways. We're very fortunate at Cabrini that we have the resources to fund a full-time data manager who helps with this process. So at this stage, if I operate on somebody this afternoon, I enter in the data about what operation was performed, the ASA score, etc. Background comorbidity data, and then follow-up data is entered in combination between the clinician and by the data manager as well. At the major public hospitals, we're also using the senior trainees, such as the fellows and registrars, to assist with that process. So, yep, it is all clinician entered. At the moment, the hospitals are not playing any substantive direct role in this process, and that's how we maintain this agnostic process. I hope that with time, that the outcome data that's published from these data sets, and the BCCA produce an outstanding annual report with sub-reports to all the training hospitals so they can see where they sit in relation to the other training hospitals. This will become so valuable to the hospitals and to third-party providers such as insurers and government agencies that they'll be encouraged to help fund this process to maintain it in perpetuity.
Great, thanks, Paul. Another question here is, as we progress collections, are we confident that risk adjustments are going to be sophisticated enough to avoid unfairly penalising hospitals that treat higher acuity conditions versus those that do not?
Yep, I'll take that one. That's fine. I think I'm not quite sure who answered that question, but if it was a CSSANZ member, they'd be well aware that all of the clinical outcome data from both the extended data set and the BCCA, when there are comparatives of hospitals, it's all risk adjusted. And there's a number of risk adjustment processes that can be used and are being used. And there's collaborative research projects through the BCCA and through our own department, and together with our colleagues in New South Wales as well, where we're constantly updating risk adjustment stratification models both for morbidity and mortality outcomes. So risk adjustment is absolutely vital. You've got to compare apples with apples, but I think that a considerable amount of effort is being made, particularly through utilising these platforms already, to ensure that risk stratification is in place and will protect those persons who are caring for the most unwell and highest risk patients.
Thanks, Paul. A question for you, Sophia. How can a hospital select which of the ICHOM sets to implement?
Yeah, sure. So I think it's really 3 domains you'll be looking at. So there's a cultural factor, and I think we've touched on this already. So motivated and committed staff, it's a key to success. And really that the staff understands and believes in the whole process. The second factor is around the implementation efforts aligning what currently is being captured and measured. So really looking at the conditions in which large percentage of the set is already being collected, and it will make it much easier. And the third really factor is a long-term impact and potential. So looking at the patient volumes, so you could look at the large patient volumes that would enable you to build that proof of concept relatively quickly, but also the smaller ones, you know, you may want to take it easy step by step and accelerate implementation, really, yeah, as I said, step-by-step mode. And finally, the cycle times. So shorter times allow you to measure outcomes faster and implementing the change faster. So for example, we have a cataract set where we really measure the outcome for patients within the 30 days post-surgery versus the chronic conditions where you would be following patients throughout their lives.
Thanks, Sophia. I have a question here from Melinda. How are patients involved in the ongoing governance of the PROM set and usage? Paul, Professor Paul, you're on mute.
I'm off now, isn't it? I'm told now that I've got to stop saying that to people myself. It's one of those modern day faux pas, leaving yourself on mute. Sorry about that. Look, it's an excellent question. We've got patient advocates involved with the governance structures of the clinician-led databases, and hence, as it stands at the moment, the PROMS program comes under the governance of the Monash Cabrini database and the Alfred database. And so we have patient advocacy both in the governance model and through patient advocates affiliated with Let's Beat Bowel Cancer, and through our Human Research and Ethics Committee as well. So they've been involved to those levels. Now, as this is rolled out more generally, it depends, of course, through which platform it's taken up. If it's taken up through the BCCA of the Colorectal Surgical Society, then there are patient advocacy groups and patient advocates involved with that governance process as well. So it's just essential in 2022 that there's appropriate patient advocacy at all levels. And of course, even the development of the data set through ICHOM involved patient advocacy, as Sophia's outlined.
So we're coming to the end of our time here. So we might just go around each of you one last time. And if you could give one bit of advice to people that are looking to implement a project such as this around the collection of PROMs, what would it be? So we'll start with you, Ron.
I would start by something that Michael Porter usually says. It's just start. Don't look to map it all from A to Z. Just start with a minimal set and iterate as you go.
Sophia?
I would say that's from the experience working with quite a different clinical departments. I think really start small, test and look for quick wins. And this will allow you to bring the staff and patients on board. And
Paul, last word with you.
Collaborate with people. Don't try and start from the ground up. There are now fantastic collaborative platforms available in the clinician-led data sets, PROMs, and in data set management such as ICHOM has in place. Don't try and start from scratch. Collaborate with those groups and use accepted data sets. You know, there was a review paper on colorectal cancer PROMs published about 2 years ago now, and I think out of the 60 groups, there was only overlap between 2 of them. All of them otherwise were just completely disparate data sets. Don't make that mistake. Use the same data sets as other groups.
Thank you so much for your time today. We really appreciate having you here, Professor Paul McMurrick, Dr. Sophia Dasgupta, and Dr. Ron Tenenbaum. It has been a really interesting webinar, so thank you very much for your time. If you are interested to know more about value-based healthcare and the Australian Centre for Value-Based Healthcare, we host regular webinars on topics related to value-based healthcare. You can find these webinars on the Australian Healthcare and Hospital Association events page. And we also, if you want to find out more, have a newsletter that you can subscribe to on the Australian Centre for Value-Based Healthcare. Thank you again for joining us, and we look forward to seeing you at one of our upcoming events.
Thanks very much.
Thank you.
Thank you.